help.
Hello, good morning, and welcome to today's presentation on how we can manage preeclampsia. Now, since the main problem is with the placenta, the ultimate treatment of preeclampsia is to deliver the infant and the placenta. And over here, we must take into consideration the gestational age of the fetus as well as the severity of the disease. Usually, after delivery of the fetus and the placenta, the symptoms, resolve within 24 hours. We must, however, try to control the blood pressure with the appropriate antihypertensive drugs, which we shall look at very soon. However, if the fetus is preterm, then we must manage this woman accordingly and give corticosteroids. And these corticosteroids, such as dexamethasone, should be given to help with the fetal lung maturation. Also, if the fetus is term, then we must induce labor and try or make an attempt to conduct vaginal delivery. One thing we must take note is that if preeclampsia develops at term, there is no advantage. We gain nothing from delaying delivery. However, if preeclampsia develops before term, then we must make a compromise over here, between the maternal and fetal health. And so over here, we must ensure that the mother's blood pressure is controlled for as long as possible, in order to allow for the fetus to grow, or the growth of the fetus to be optimized. However, if the fetal or the maternal condition begins to worsen or to deteriorate, then we must expedite processes to deliver this baby. Now, we have to also commence prophylaxis for eclampsia. That is, we need to give some drugs to prevent the woman from getting into eclampsia, which is the seizure or the fit aspect of this condition. And we can give magnesium sulfate to this woman. We shall look at it into details how to administer this magnesium sulfate. Now, this woman complains that her headache is worsening and she is seeing flashes of light. She's also found to be hyperreflexic and also having clonus. And she's given a dose of oral labetalol 200 milligram. At this stage, her blood pressure is being monitored every 15 minutes. And despite the oral antihypertensive, her blood pressure remains high at 170 over 120 millimeters per mercury 2 hours afterwards. So what will be your diagnosis at this moment? And which antihypertensive drugs are suitable for this woman at this stage? Obviously, this woman is having severe preeclampsia, and this severe preeclampsia is a threat to this woman's lives as well as the life of the fetus. And so we must do everything possible to save the two of them. Now, the antihypertensive drugs which we can give, and even before that, our aim in the use of antihypertensive is to control the blood pressure to below 160 and 110 millimeters per mercury to prevent any maternal morbidity, especially from cerebrovascular accident, encephalopathy, and also even myocardial ischemia. So this is our aim of initiating or starting these antihypertensive management. So the antihypertensives which may be suitable in this case may be labetalol. Now, when we give labetalol, we can start with 25 milligram IV bolus, and in this case, we give 5 mils of 5 milligram per mil of this drug over at least a minute. Now we can repeat this dosage after 15 minutes interval to maximize, or to a maximum of 200 milligram until the blood pressure is controlled. Then after that, we can start the infusion. Don't forget, we want to have a blood pressure below or at 160 and diastolic at below or at 110 millimeters per mercury. So once we have this, we can maintain, or we can continue with labetalol infusion by having diluting 200 milligram of this labetalol, that is 40 ml of 5 milligram per ml of this drug, with a 10 ml of normal saline, 0.9% of sodium chloride of normal saline, and we can start this maintenance infusion on this woman. In this case, we are giving the concentration of 4 milligram per ml. Now, when we start with this, we can continue this infusion at 5 ml per hour, and this will give us 20 milligram per per hour. We can even double the infusion rate every 30 minutes to a maximum of 40 ml per hour, which will give us 160 milligram per hour. We can also titrate to keep the diastolic below 90 to 100 millimeters per mercury. Now, one thing we must note over here is that we must avoid labetalol if this woman is an asthmatic. This is because there is evidence to show that it causes decrease in the fraction of expired volume in 1 second in asthmatics, and this often precipitates asthmatic attacks when used as an antihypertensive. And so we should take note when we are giving labetalol to asthmatic patients who also have this preeclampsia. Now, the other thing that we need to note over here is if the woman remains hypertensive, on a maximum rate of labetalol, and still the blood pressure is still high, or even if labetalol is contraindicated or it is causing side effects, what we can do is we can add, or we can even replace this labetalol with hydralazine infusion. Now, over here, what we can start is give hydralazine bolus of diluting 40 milligram hydralazine in 40 ml of normal saline to give a concentration of 1 ml or 1 milligram per ml. So with this, we give 5 ml slowly, over 15 minutes, or we can even use an infusion pump and set it at 20 ml per hour. Whilst we are doing this, we need to be checking the blood pressure after every 20 minutes. And if the diastolic has fallen below 100 millimeters per mercury, we can give 5 milligram over 15 minutes, or even use again the infusion pump at a rate of 20 ml per hour. Now, when we have the diastolic, falling to about 90 to 100 millimeters per hour, we can commence, hydralazine, maintenance infusion. Now, before I continue with this hydralazine, it is important for us to note that this hydralazine may cause headache, sometimes tremor, nausea, and even tachycardia. And it sometimes may be less tolerated even than the labetalol. Yet we can continue to give the infusion when we have recorded the diastolic between 90 and 100 millimeters per mercury. So in hydralazine infusion, we use the same concentration as we've already seen, 5 milligram per hour, which will give us, which is 5 ml per hour. So we titrate till we also get a diastolic of 90 to 100 millimeters per mercury. That's for the diastolic, and also systolic of 140 to 150 millimeters per mercury. Usual maintenance dose is usually up to 2 to 3 ml per hour. Now, the maximum dose that we can give as infusion using hydralazine can be 18 milligram per hour. We can also reduce this rate when we have significant side effects, such as the ones I've talked about, such as the headache, the tremor, and the nausea, or even if there is maternal tachycardia of more than heart rate more than 130 beats per minute. Now, after managing the blood pressure, the diastolic falls to 90 millimeters per mercury. We are continuing to monitor the SpO2, the saturation of oxygen, the heart rate, and also the respiratory rate. We are doing this in every 15 minutes. And whilst we are considering, a plan for delivery of this fetus, this woman gets, grandma fit. So in this case, what is the most likely reason for this fit, and how should we manage it? This and many more are going to be what we are going to look at in our subsequent video. Thank you very much for your time.